All right, perfect. All right, perfect. Well, thank you so much and welcome everybody. Thanks for joining us today for the Bay Harbor Islands Joe DiMaggio Children's Hospital Kids Health and Safety Series talk. As most of you know, we do this on the third Wednesday of every month at noon. We've had a lot of exciting and wonderful topics, and we're particularly excited about today's topic because of its relevance. Today, we're going to be talking about COVID in kids. So I'm going to introduce our two speakers. First, we have Dr. Ale, and I have to read her bio because it is very impressive and there's no way I could have memorized this. So Dr. Ale is a pediatric immunologist and allergist here at Joe DiMaggio Children's Hospital in Hollywood, Florida. She was part of the inaugural class of the FIU Herbert Wertheim College of Medicine and graduated with honors in 2013. She then pursued her residency in pediatrics at Nicholas Children's Hospital, though we shouldn't mention that name because they're the competitor, just kidding, but graduated top of her class. In July of 2018, she also completed her fellowship in allergy immunology from Nicholas Children's Hospital in combination with the Cleveland Clinic, Florida, and then joined the Division of Allergy and Immunology here at the Superior Hospital, also known as Joe DiMaggio Children's Hospital, later that same year. Dr. Ale enjoys research and has presented several research projects on multiple national and international allergy and immunology meetings. She has published her work in prestigious journals such as Pediatrics in Review and the Journal of Allergy and Clinical Immunology in Practice. She's passionate about primary immunodeficiencies, especially 22q11.2 deletion syndrome. She is the immunologist and the medical director of the 22q multidisciplinary clinic here at Joe DiMaggio Children's Hospital. In addition to providing patient care, Dr. Ale is a member of the Alpha Omega Alpha, or AOA, National Medical Honor Society, an organization with commitment to scholarship, leadership, professionalism, and service. She was awarded with the FIU 2018 Torch Award as Distinguished Alumna, which is the highest honor bestowed upon alumni and faculty of FIU. Most recently, she was invited to teach the immunology course to the first-year medical students at the Herbert Wertheim College of Medicine. Dr. Ale is a dedicated and enthusiastic young physician who's very passionate about the field of immunology, and we're so happy to have her as part of our group here at Joe DiMaggio Children's Hospital. While I have your attention, I'll also introduce Dr. Chang, and then I'll turn over the Zoom, I guess, microphone, whatever you want to say, to our distinguished speakers. So Dr. Chang, I see Dr. Chang is on right now. I'm glad you're able to join us. Hopefully your consult went well. Is currently the Chief of Pediatric Immunology, Allergy, and Rheumatology here at Joe DiMaggio Children's Hospital and Memorial Healthcare System. He is Professor of Medicine at the University of California, Davis, and Professor of Pediatrics at Florida Atlantic and Florida International Universities. He is a fellow of the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and member of the Clinical Immunology Society and the American Association Immunodysregulation, Primary Immunodeficiencies, and Autoimmunity, as well as Epigenetics, Eczema, and Food Allergies. He's Associate Editor of Clinical Reviews in Allergy and Immunology and co-editor of the Journal of Translational Autoimmunity, and has himself authored over 130 original manuscripts, that's a lot, and 40 book chapters, which is very impressive. During the COVID-19 epidemic, he has given monthly to bi-monthly updates on COVID-19 science and research to the medical staff of Memorial Healthcare System. He's been an invaluable resource here at Memorial, and I can tell you he's one of the physicians at Joe DiMaggio. We so appreciate both Dr. Chang and Dr. Ale. And so without further ado, I'm going to turn over the Zoom joining us today.
Thank you, Dr. Levine. That's very nice. So I'm going to start sharing my screen since I'm going first. Give me 1 second.
So Regine, I think you have to make I think you have to make her a co-host, if I'm not mistaken. Is that right? For her to be able to share the screen? Are you able to share it or no?
I am trying. Host disabled participants.
I try to make her a host.
And sharing. I can.
Sorry,
Host disabled participant screen sharing.
Regine, can you make her a co-host, please?
Yeah, just give me a second. I was getting her on there. Just give me a second.
Okay. Okay, perfect.
Yeah. Okay, so it should be. Oh my God, what is this? Okay, in a second. This computer is so complicated. I don't understand why so many questions just to share my screen.
That's what happens.
Are you I know. I'm in a Mac. That's why. Oh my God. I thought I had everything figured out and this happens. Give me just 1 second.
If you want to email me the talk, I can try to put it up and share if that's going to be easier.
Okay. Open. So let's do that if you don't mind.
Do you want to make me a host and see if I can share it?
Sure, I'll add you as well.
And we'll see if I get the same questions that Dr. Ali got.
You're using your Mac? Oh,
Yeah.
oh.
It's a
We'll get it to work though. Sorry, everybody.
Yeah, we apologize.
Oh, I might be able to. Let's see. Nope.
Okay, we see.
Hang on,
We see
sorry.
your email.
It's not okay.
Yeah.
Okay, so
Alright.
I just made you a host.
Do you have both of the talks, or did you need me to do?
I have both. I have both. I just give me
No
a
problem.
second to open it up. No, that's not it. Okay. 1 sec. I have to get the talk up first. Okay.
Oh, I think I can share it now.
Oh, good.
Can you see
Okay.
this? Okay, yay.
Yes.
And then I'm actually in the sides too. This is very funny. So can you see me on the side? Okay, I think I'm ready to start. I figured it out. Okay, so let's, hold on. I'm sorry, this is not the one. Oh, I apologize. Okay, this is the one. Okay, I'm so sorry. Now we're ready. So as we all know, the COVID-19 virus came to shake our entire world and change our lives drastically in just a few weeks. It affected every one of us and especially our children. So COVID also changed the way we think about medicine, the way we think about the immune system, the way we think about healthcare, about healthcare professionals, and the concept of vaccines. So I will start our talk today with a brief overview about vaccines in general to refresh some important concepts about immunizations and why we do it before we dive into the COVID vaccine specifically. So I want to kind of refresh, what is a vaccine? So a vaccine is a substance used to stimulate the immune system for the production of antibodies to provide immunity against one or several diseases. So what is the goal of vaccination? Well, the goal is to improve individual and public health by preventing or decreasing the impact of induced disease, preventing or reducing also the spread of infection in a population. And vaccination is one of the few opportunities for personal health benefit to be amplified as a benefit of the greater population. And because we're immunologists, we're in the front line of pro-vaccine doctors, right? So we truly believe in the importance of vaccinations as a very fast and efficient method of achieving what we call herd immunity. So what is herd immunity? It is the creation of a widespread immunity on the general population for specific disease, and is achieved by vaccination. So we can protect those individuals who are not immune or cannot receive immunization due to very specific reasons. So we have been hearing about herd immunity since the COVID vaccine, it started to being developed. And now we are in the process of achieving herd immunity by vaccinating the population with this vaccine. And then Dr. Chang is going to talk about that more. So in other words, very simple, we vaccinate those who can be vaccinated in order to provide a measure of protection for those who cannot. And the only reason why I've decided to put this table up is to show up the numbers, the benefit of vaccination and how effective they have been through the years on eradicating disease. As you can see, there's a clear significant impact when vaccines are implemented of the population. For example, let's take the example of measles. So measles in between the years 1959 and 1962 had a yearly prevalence of over 5,000 per year. And then the modern prevalence of measles is only 187 cases per year. So that is a percent reduction of over 99.9%. For example, smallpox from 1900 to 1904, it had a yearly prevalence of 48,000 cases. The modern prevalence is 0. So that is 100 vaccination. There are vaccines that are still developing, like the HIV, HSV, Ebola, chikungunya, and Zika vaccine. But thank God we were able to get the vaccine for our current pandemic. So let's just talk a little bit about how vaccines are made. So what are the strategies that we use to make vaccines? So the first strategy is to weaken the virus. So in that, with this concept, viruses are weakened, so they reproduce very poorly once inside the body, and consequently don't cause disease. But they do activate the immune system to create immunity. Examples are what we call live viral vaccines, which are the MMR, the rotavirus, the chickenpox, and the influenza, the intranasal version of the influenza vaccine. So the second strategy is to inactivate the virus. So in the first strategy, the virus is weakened, but still alive, but very weakened, so it doesn't cause disease. But in this case, the virus is completely killed. And how do we do that? We killed it with a chemical, so it cannot reproduce itself or cause disease, but it's recognized obviously by the cells of the immune system and is able to cause immunities. For example, we have the polio vaccine, the hepatitis A vaccine, and the influenza vaccine, the shot that we get, and also the rabies vaccine is an inactive virus vaccine. The third strategy is to use part of the virus. So in this case, the vaccine is composed with just a piece of the virus, and it's usually a protein that resides on the surface of the virus. Like, for example, for the coronavirus, it has like the capsid proteins on the outside. So it's similar for many other viruses. So this is the strategy by using just a piece that is recognized by the immune system. And then it creates protection against that disease just because of that piece of the virus. Hepatitis B, shingles, and the human papillomavirus vaccine that the teenagers get is made using this strategy. Another one is to use part of a bacteria. So some bacteria cause disease by making a harmful protein called a toxin. Several vaccines are made by taking a toxin and inactivating them with a chemical also. And this toxin will no longer cause disease, but yes, it activates the immune system. So the famous Tdap vaccine that we give to the kids are this type of vaccine. And also on the same token, there is another, the same, like another strategy on the same concept. And this is used to, we use the part of the sugar coating of the vaccine, of the bacteria to make the vaccine. Since the protection against the infection is based on immunity to this sugar coating and not the whole bacteria itself. So the famous pneumococcal vaccine, the Haemophilus influenza vaccine, and the meningococcal vaccines are examples of vaccines made using this strategy. Then last but not least, we have the most recent way of making vaccine and the most revolutionary, which is to provide the genetic code for part of the virus. This is the DNA, the mRNA on the vector viruses vaccines. So let's start with DNA vaccines, and it is just the DNA, the blueprint code that is used to get another code called messenger RNA. So the messenger RNAs, they will serve to make as a blueprint to make the viral protein, and the immune system to recognize it as foreign will respond and create immunologic memory. However, currently there's no vaccines that are made with DNA that are available. However, we do have mRNA vaccines, and these are the Pfizer and the Moderna COVID vaccines. So the way we do create these vaccines is the vaccine will contain the messenger RNA, which is a code or the blueprint to create the viral protein in our own bodies. Okay, the vaccinated person, dendritic cells use this blueprint, receive the mRNA, and makes the viral protein that way. Once the immune system realizes that there is a foreign protein being made, it creates an immune response against it, including also immunologic memory. That way, the next time the person is exposed to the virus, then the immune system is ready to respond rapidly. Then the other strategy is vector viruses. So it's also delivering a code, but it's in this way it's delivered by a vector. In this case, the vector will be an adenoviruses that, yes, it causes disease in people, but these vectors are genetically engineered so they cannot cause disease and just work as a carrier with the genetic information of the virus that we want the immune system to create the response to. The example of the vaccine that is made this way is the Johnson & Johnson Janssen COVID vaccine, and it is the vector adenovirus vaccine. So these vaccines are actually, what I wanted to say is the two vaccines, these vaccines can be given to immunocompromised people. And I'm going to talk a little bit more about that. But I just wanted to say, because of, how important we need to make sure we stress the importance of vaccines, especially in our audience today, which it's general pediatrician and the parents, because vaccines have been able to create as big as a 14-fold reduction of mortality from infectious diseases in the last century. Approximately 33 lives are saved from every birth cohort vaccinated, and it has prevented 40 million cases of disease. So it's major. Vaccines are, we obviously as immunologists I always say, we are the very pro-vaccine doctors, but we want to make every doctor pro-vaccine doctor. If we explain how the vaccines work and how they are made, maybe we make the parents to understand why is it important, and obviously all doctors to explain to the parents why we need to vaccinate our babies and the population in general. So I wanted to talk also, because we're immunologists, I have to address the immunization in immunosuppressed individuals. So live vaccines should not be administered to severely immunocompromised persons. That's why we ask the pediatricians or any doctor that is worried that a patient has a compromised immune system to send it to us, so we can do the necessary testing to see if that person or patient can be vaccinated. However, inactivated vaccines are safe to use in immunocompromised patients, but the response might be decreased, that's true. And then again, the mRNA COVID vaccine viruses, the Pfizer and Moderna, can be given to people who are immunocompromised, but it requires 2 doses to be protective. So I want to also address what are contraindications of vaccines that are not valid, okay? So if you have a mild illness, you can get vaccinated. Also, if you are receiving antimicrobial therapy like antibiotic or an antiviral, yes, you can be vaccinated. If you have had exposed to the disease or convalescence from the disease, you can also get vaccinated. If there is a pregnant woman in the household or an immunocompromised person, yes, you can also get vaccinated. And also if you're breastfeeding, I have to disclose that I got my COVID vaccine when I was breastfeeding my baby. Because I was breastfeeding my baby, it was one of the things that made me push through the hurdles of breastfeeding and how hard it is for a working mom to pump and do all those things, because I knew that I was creating antibodies, and giving it to my baby for me was major to continue breastfeeding. So yes, you can get a vaccine and breastfeed. Babies that are preterm can also get vaccinated. And then if you're allergic to products that are not present in the vaccine, obviously, and that is not an allergy, that is anaphylaxis, you can get vaccinated. And there is family history of adverse events. That doesn't mean that you will have an adverse event. And yes, you can have multiple vaccines at the same time. We do it for babies all the time. And also a positive tuberculin test. What adverse effects are expected, and what are the unexpected ones that we get worried about? So expected is always a local and systemic reactogenicity, meaning the soreness that we get on the arm, fever, general malaise, but that doesn't impact eligibility for future vaccines of the same kind, okay, or any other vaccines. What are other unexpected events? Obviously, an allergic reaction, or if you get a seizure or Guillain-Barré syndrome, generalized joint pain, and yes, this likely has impact eligibility for future vaccines of that kind. So that now I'm going to let Dr. Shan take over and talk about the COVID-19 vaccine specifically.
Thank you, Dr. Ali. Dr. Ali, do you have the rest of the slides of my slides, or should I share?
I can definitely do that for you. Give me 1 second. I thought it was this one, but it's not, right? Oh, there you go. Yes, it is. Okay. I'm already sharing, right?
Yes.
You see, can you see this, what I'm pulling up?
I still see your last slide.
Oh, okay. Okay, you can see that I'm soon handicapped for some reason.
If not, I can try to. I can share mine. I have to
Maybe
find
if
here. Okay. Let me see. Okay, let me share mine then.
Okay, because I'm still trying to figure it out. I apologize.
Let me.
Oh, I know. I have to stop sharing.
See if this works.
I think we do so much WebEx that I have forgotten about Zoom.
Yeah. So let's see. I think I'm sharing now. I started on the same slide you had on, so it might be hard to tell. But let's see. Did you see the slide change?
Yeah.
Okay, so I think I'm sharing now.
Okay, great.
All right. So just to continue on the discussion on COVID vaccines, as you know, there are 3 vaccines in the US that are currently under emergency use authorization that was granted by the FDA. But there are many more trials that are being conducted globally now, and there are actually many, many other vaccines that are available already globally. This graph is from the World Health Organization vaccine landscape for COVID-19, and as an Excel file, you can go in and you can download a updated spreadsheet of all the vaccines that are in development, and they update it twice a week, I think. So you can see that there are 184 COVID vaccines in preclinical development, and then there are an additional 100 in clinical development. In other words, they're in human trials. So if you look at the type of vaccines that they're studying, you can see that these protein subunit vaccines, or PS, those are the most common ones that are being developed. But you can see that RNA vaccine, which is the also comprise a number of vaccines that are being studied. And as Dr. Ali mentioned, you have the vector viruses, and you also have these attenuated viruses that are being developed. So there are many, many vaccines that are being developed for COVID-19 right now. But so far globally, what's available, there are 3 in the US, as Dr. Ali already mentioned. The AstraZeneca vaccine, I don't think is available in the US, but is available in the UK, and they've given quite a large number of doses of this vaccine. There are multiple vaccines being developed in China, and there are 3 that are most commonly heard of: Sinovac, Sinopharm, and CanSino. And these are generally adenovirus vector vaccines. And then you may have heard of the Sputnik 5, which is the vaccine that was developed in Russia that is actually being used in Russia and other countries. So as people develop more and more of these vaccines, they're being used in their country in which it was developed, but they're also being exported for use in other parts of the world, which is very important because you do want a global response you want global availability for vaccines, and not just restricted to one region or one country. So the current vaccination rates, as of yesterday, in the US, 47.7. So almost half of the people have received the first dose. A little more than a third of the people are fully vaccinated. And we have used about 80% of current supplies. Now, as you may expect, the supplies are ongoing, the production is ongoing. And so, there'll be more and more supplies. So this number here, 79.5, is a moving target. In Florida, we're just a little bit below the national average, at 46% having received the first dose and 36% fully vaccinated supplies. If you look at which states are doing the best in terms of vaccination and the worst, Massachusetts has the highest number of first dose and the highest number of fully vaccinated, highest percentage of fully vaccinated people in the state. And then Louisiana and Alabama have the lowest number of lowest percentage of first doses given, and the lowest percentages of fully vaccinated individuals. So special groups, we started off giving this vaccine to adults, and we started off giving it to healthcare workers and elderly people. But now the indications have been broadened, and for the Pfizer vaccines, the study was actually done on patients down to age 12. It took a little longer for the data to be analyzed. I could not find a publication on the use of the vaccine in people at age 12 yet, but I'm sure that'll be published. But even prior to the publication, once the company, which is Pfizer, submitted their data to the FDA did approve an EUA, emergency use authorization, for children 12 years and older. There was a recent paper in JAMA that showed the vaccine showed immunogenicity. That means able to mount a response in 103 patients, pregnant and lactating patients. And then a review paper in the Journal of Maternal and Fetal Neonatal Medicine suggests that the vaccine is safe in pregnancy and breastfeeding. However, they cautioned that the numbers that were studied were very, very small. And so that definitive conclusion shouldn't be made, but it does appear that they're safe for pregnancy and breastfeeding. And then, as Dr. Ali already mentioned, patients with immunodeficiency or autoimmune disease, our general recommendation is that they should be given the vaccine. The vaccine is not a live vaccine, so it doesn't have the capability of causing disease. But we always caution that in your own individual cases, you should check with your immunologist or your rheumatologist. Patients with allergies can receive the COVID-19 vaccine, and see your allergist if you're unsure. The CDC actually has guidelines to receive the vaccine. So if you're allergic to a COVID vaccine, so in other words, if you had anaphylactic reactions to the first shot of a COVID vaccine, then don't get the second shot. So if that was to an mRNA vaccine, which is really the only vaccines in the US now that you get 2 shots of, don't get the second shot. But you can get a different type of COVID vaccine. So if you have anaphylaxis to, say, the Pfizer vaccine, you cannot get the Pfizer or the Moderna, but you can get the J&J vaccine. The same thing with non-severe allergic reactions. The CDC advises that you don't get the second shot of a similar vaccine. If you only have a skin reaction, it's colloquially called a COVID arm, then you can get a second injection. This is not a contraindication to getting a second injection. If you're allergic to another vaccine in the past, or any kind of injection therapy, you can get this COVID-19 vaccine, but the advice is to monitor for 30 minutes. If you're allergic to any ingredient in an available messenger RNA vaccine, then don't get that vaccine. And if you're allergic to any ingredient in the J&J vaccine, then we advise you not to get this vaccine. But if you have allergies not related to vaccines, then you can get the COVID vaccine. And this is true even in patients who have very severe allergic diseases like mastocytosis or mast cell diseases. They are still eligible to get the COVID vaccine. All right, so we talked about the components of the vaccine. And really, this is components in the Pfizer, the Moderna, and the Janssen vaccines, in addition to the component at the top of that table, which is either the messenger RNA or the adenovirus carried a vaccine. One of the biggest components of these vaccines is lipids. And the reason lipids are basically just fats or soaps. And the reason that lipids are so important in these vaccines is as a stabilizing agent or protective agent or packaging agent, because especially with the Pfizer and Moderna vaccine, these vaccines are RNA vaccines, and RNA is very, very susceptible to degradation. So in order to keep these vaccines stable, this is the reason why they have to be frozen at low temperatures, but they're also packaged in a protective envelope of these lipid molecules. And it is these lipid molecules that actually cause most of the allergic reactions in vaccines. So polyethylene glycol is used in both the Moderna and the Pfizer vaccine. And this is the component that is thought to cause an allergic reaction to these vaccines. And with the Janssen, polysorbate 80 is the lipid component that is thought to cause allergic reactions. So if you're allergic to any of these components of the vaccine, then you shouldn't get that particular vaccine. All right. So now that we have vaccines, I think everybody was very, very happy that we had vaccines, because it seemed like there was light at the end of the tunnel and that we could get over this very, very long COVID pandemic that has been really disrupting our lives for so long. But what are the challenges to successfully eradicating COVID-19? Now, eradicating is different from achieving herd immunity. Eradicating means that the disease isn't around anymore, except perhaps in a laboratory. So it's very, very difficult to eradicate an infectious disease. In fact, there are only 2 diseases that have ever been eradicated from the face of the earth. One is smallpox. And when we say eradicating, it means we don't see any more cases. It doesn't mean that smallpox doesn't exist. But smallpox is one. And the other one is actually not in humans. It's rinderpest, which is a cattle infectious disease. That's the only other disease that has been eradicated. achieving herd immunity means getting enough people immunized or getting enough people who are immune to the virus so that it doesn't spread, so that you can minimize the outbreaks that might occur. And one of the challenges that it's already difficult to achieve herd immunity in the best of circumstances. So in a disease like, I just gave an example here, this is based on a calculation, which is not perfect because things change. But if R naught is 4, and R naught is the amount of people, the number of people that can be infected by one person. So if one person can infect 4 people, and this is based on epidemiological studies, then if you assume that the vaccine efficacy is 100%, that means everybody who gets the vaccine is protected and cannot spread the disease. Then if your R naught is 4, then you need 75% of the population to be immune or to be vaccinated. All right. But then if your vaccine efficacy is only 80%, then this number goes up even higher, and you need 94% of people to be vaccinated in order to achieve herd immunity. So that's really, really high. I mean, you need almost everybody to be vaccinated. Other challenges to successfully achieving herd immunity in COVID-19 is that there are now variants, and variants may play a role in the vaccine efficacy. And the third thing that is a challenge is vaccine hesitancy. Right. So if we want to talk about variants, there are a number of variants that have emerged since. Some of these you may have heard of, the UK variant, there's a South African variant, there's a Brazil variant, there are a couple California variants, there's the India variant now that the disease is now so widespread in India, and there was a New York variant also, and all of these variants have different names, and they have multiple mutations that evade vaccines, evade our immunity. And so while our evolution is very, very slow, the evolution of vaccines is very, very fast, because they're smaller and they're not as complex, and they reproduce faster. And so every time they have a new generation, they can mutate, and so they mutate much faster than we do. So there's some evidence that shows that these variants may have increased transmissibility, which will change your R naught, and may also result in increased mortality, which means more severe disease and death. And then when you look at the vaccines that are out there and how they protect against the wild type, in other words, the original virus, and how they protect against the variants, you will find that maybe some of them don't protect as well against some of the variants. Now, it really isn't a question of whether they will protect the variant. It's really a question of how well they will protect against the variant. It's not an all or none deal. So if they don't protect as well, then you could have more cases break through. And that's already been shown in some patients who received the Pfizer and the Moderna vaccine and still developed COVID-19. And when they looked at the DNA sequence of the COVID-19 that they were infected with, they found that it was one of these variants. So variants, can really hobble our efforts to achieve herd immunity. The other challenge was vaccine hesitancy. And remember when I showed you that we need to maybe 75 to 90% of people to be immunized to receive herd immunity? Well, this was a survey done asking people if they were likely to get a vaccine if it were available. And they asked them in April of 2020, and they asked them in December of 2020. And if you look at the numbers and compare them, you'll find that people who were surveyed in April of 2020 were much more likely to say they would want to get the vaccine than people in December. In fact, in all of these cases, there's a drop from 10 to 20% of people say they would likely get the vaccine. So this is a big problem. None of these numbers are anywhere close to what we need for herd immunity. And in one paper that looked at different countries, again, you can see to get the vaccine, and 23% in Taiwan, but then you also have to take into account that Taiwan has very, very few cases. There were only 611 cases in the US, for example, and there were only 7 deaths. So people generally would not be as compelled to get the vaccine if they're not seeing a lot of people getting sick and dying. But again, in most of these countries, the likelihood of people wanting to get the vaccine is still very, very low compared to what we need to see in order to achieve herd immunity. So I just wanted to touch on the new CDC guidelines because a lot of people are having questions about this. And the CDC has recently stated that people who are vaccinated need not wear a face mask or observe social distancing. So the question is this really good advice? It has created a lot of confusion, mainly because it's a marked deviation from the previous recommendations. So they went from being almost overcautious to being not at all cautious. And so there's been a lot of confusion among people as to what to do. I think that the intended message that why the CDC made this recommendation is because they wanted people to get vaccinated, and they wanted to use vaccination as or they wanted to use not having to wear a mask as motivation to get the vaccine. Unfortunately, I think it backfired because I think the message received by the public is that life is getting back to normal and nobody has to wear a mask anymore, social distance. So the result is that many unvaccinated people are not wearing masks or social distancing because they're not enforcing this. They're not checking to whether or not you got the vaccine and seeing and then letting you know whether you can wear a mask or not wear a mask. So and the problem with this is somewhat resistant to the current vaccines, and so it's still out there, and the numbers are still pretty high in the U.S. Even though they are nowhere near the peaks, but they're still pretty high. The potential outcome is that we have increased numbers of COVID-19 cases and increased mortality, and this will drag on longer and longer and longer. So I think that was my last slide. Yes, and so Dr. Ali and I would be happy to take questions.
All right, well, thank you both so much. That was really interesting, very informative. I actually have a couple of questions and then we'll see if other people also have questions as well. But for one thing is that I know that we've had some parents that are asking how they can go about getting their children vaccinated. Their children that are 12 years old and older vaccinated. And if they have children that are younger, are there studies available? And should they just talk to their pediatrician? Should they reach out to you? I mean, how do people go about doing this?
Yeah, so I know that Joe DiMaggio is giving vaccines to 12 and older. And so I think those recommendations will be coming out soon. I don't know when, nobody knows when, but I think they'll eventually will be able to vaccinate everybody.
Okay, great. And then also, is there any sort of benefit? Let's say that you've been vaccinated with the Pfizer vaccine before. Or is there any benefit to also getting the J&J vaccine or to getting one of these other types of vaccines? Has there been any data that's shown, utilization of different vaccines in the same person?
I don't believe so. I think that the only way people were getting that were in England when they kind of started mixing vaccines, and I don't know that there's any good data out there yet. There is talk about booster vaccines though, and whether or not you need to get the same vaccine for your booster as you got for the original series is a question. We don't have the answer yet. I imagine that these vaccines, the whole idea of the vaccines is to generate an immune response. In theory, if you had one vaccine and then you got a different vaccine for your booster, it would help. It would help boost your immunity in theory. But I don't think we have any quantitative data on whether or not one would be better than the other.
Okay, great. And it looks like we have a question.
Hi, thanks, doctors. I was just wondering, since we don't know the length of time of the efficiency of the vaccines, with the CDC guidelines being about removing masks, within the next like 3 months, 4 months, will we see a spike if people follow those guidelines? Because assuming that the vaccine is only effective for 3 months or however long, or is it that they'll remove the guidelines for these 3 months and then we're gonna have to put the masks back on in 3 months, 4 months? Where do we go from here? Because it kind of feels like it's opening a can of worms.
Yeah, that's a great question. That's a really good question. The studies that have come out of the vaccine trials have shown that the Moderna and Pfizer vaccines seem to be able to generate your immunity lasting up to 6 months. But because this is so new, we really don't know beyond that. And so, you raise a good point for two reasons. One is that if we start taking off our masks now and there are variants out there and then the numbers start going up, is the CDC going to reverse their guidelines? I mean, there's already been a lot of criticism of, that very sudden, just a change of heart that they had from, masking until not wearing masks at all if you're vaccinated. So I think we'll just have to see, down the road what happens with the numbers and the variants that have been appearing of late.
I think the problem that that brings the complete change on remove masks if you're vaccinated is that if people are claiming they're vaccinated not to wear a mask. And that is the idea from the CDC, what I'm believing is to, as you said, Dr. Chang, is to encourage people to get the vaccine so they can just remove the mask and socialize. But people are having vaccine hesitancy and they are claiming that they have the vaccine when that is not true. And that is what I think that's where the problem resides, is on those people that are not vaccinated and obviously do not want to wear a mask, and that the virus continues to be a problem in that kind of population. And obviously we are not going to be able to eradicate it if that's the issue, because we're going to have a source always there from those people that do not want to get the vaccine and do not want to wear a mask either. And they're saying they have wear the vaccine, they have gotten the vaccine. I think that's the biggest issue.
Great, thank you.
So there's another question also from Jillian Steen.
Hi, how are you? Can you hear me okay?
Yes, yep, we can hear you.
Hi, I am an occupational therapist within the Memorial Healthcare System, and I'm also a mom to an almost 2-year-old. And my question to you is, my family, and I'm sure a bunch of people are in the same boat, the adults in the family over 12 have been vaccinated, but the children have not been vaccinated because the vaccine is not available for the children. Now that they're lifting the mask mandates, does the risk of the children, getting COVID, does the exposure and the risk now increase to the children, since they're in environments where they're not wearing, they're not capable of wearing masks and capable of protecting themselves? So should parents now avoid, having their children out in the community and kind of sheltering them in place again? What do you guys recommend?
Yeah, another great question. And yes, if your children were not to wear a mask and there were people out there who, were not vaccinated and were also not wearing a mask, this is where the problem comes in. I mean, I was running this weekend and on the boardwalk in Hollywood, and I must have come across 3,000 people. It was packed, 3,000 people along my run, and I only saw 2 people wearing masks. And given that the Florida rate is of even getting the first vaccine isn't even half, I should have seen, or I should have seen 67% of the people wearing masks, not 2%. And so
Right.
You should assume that the people out there not wearing masks could still be,
Positive.
contagious. And so,
Right.
yeah, so if your kids, the only thing I can say is that, protect yourself and your kids as best as possible. Have them wear masks, you know, and I can tell you a lot of vaccinated people are still wearing masks for that reason, despite the CDC guidelines.
Right. The concern lays is that, you know, for the population under 3, children can't really wear a mask, you
Yeah.
know, so you're in agreement that the recommendation continues to keep the children younger than the age that they can wear masks, to kind of keep them away from those that you're not sure whether or not they've been vaccinated, correct?
Yeah, I mean, I think you have to do what you need to do to protect your kids. And if, you know, I mean, I would, you know, look at the situation, and if there's a
Right.
risk of, you know, being exposed to someone who you don't know, you know, whether they're infected or not, then you should keep them
Is
away from those
the
situations.
potential is always there. You know, you don't know who, if you go into a gathering, who will be vaccinated or not. If you're close family and everybody, you know, everybody has been vaccinated because it's your close family, I think you have more kind of flexibility of the kids not wearing masks and being you know, in the gathering regular with the other ones. But if you're going to a place that is a lot of people, I would say, you know, they should keep the mask on, just to protect, in case there are people that are sick and are there and are not wearing a mask. Obviously they can potentially get sick and just be asymptomatic or be very, very sick. We have seen both, you know, both sides for kids.
Right. Now, my one more question to kind of go along with what I've asked is now, what is, I don't know if there's research behind it, but as far as the transmission rate from kid to kid, you know, since children under 12 are not vaccinated currently, is the transmission rate between children, are they finding that it's higher than it was in the past now that children are starting to go back to schools and preschools, or is it kind of staying at a baseline?
Yeah, I don't know that there's been any study looking at transmission between children. It would, I think it would probably be a hard thing to study because, you know, there are always going to be adults around, and, you know, how are you sure that kids got it from other kids? So I'm not aware of any study that's done that.
Thank you for your help.
And I just wanted to say one more thing about kids. We know from experience of living the COVID pandemic that kids get mildly sick. Most of the kids get mildly sick, and then because of that, we're thinking, oh, you know, they just have the sniffles or whatever. But then there is this cohort of kids that is not just a mild disease, it's a very severe disease. And we have all heard about the MISC, which is the hyperinflammatory state in kids. And that is what I am worried about as a mom, is that very, very scary part of the COVID in kids. So it's like the Russian roulette. We don't know where the bullet is going to be. Maybe you get, you know, you have 5 kids that get the COVID, and then there is one that ends up in the ICU. You don't know if that's going to be your kid. So we always say, if the kids are not vaccinated, just protect them the best you can. And then, you know, the adults around the kids need to be vigilant of that too. It's like when we were saying, protect the elderly, protect the elderly. Now the elderly are getting vaccinated. Now we have to protect our kids.
Right. Now, is there a guideline now? Do they have a timeline as to when they think the 12 and under population will have the vaccine available, or is it still in the research phase? What do you know what phase it's in?
I don't think we have an answer. Maybe Dr. Shan will say.
No, there are research trials ongoing all the way down to 6 months, but it's anybody's guess when. I mean, I didn't even know when the 12-year-old vaccine was going to be released. Dr. Fauci has said that children would be able to be vaccinated before the beginning of the next school year. But I even think that, you know, I don't know that he has a crystal ball either to tell when they're going to actually be available.
Great. Thank you for your help. I appreciate it.
Sure.
Okay, I see we have a couple of other questions. I know we're running a little bit short on time. So Dr. Ele and Dr. Chang, are you able to stay on for an extra couple of minutes?
Sure.
Yeah, definitely.
Okay, so it looks like I think Audrey Ann Levine was next for questions.
This has to do with a time frame. We received as adults our second vaccination in March. I called Moderna to find out when we would be fully immunized. I was told it would take 4 months, which brought us up to April. 4 weeks, which brought us up to April. You had mentioned we may need boosters after 6 months. Does the 6 months count begin after our second shot, or does it begin 4 weeks after our second shot?
I think these are kind of approximate timelines. I said possibly 6 months, but we really don't know what the recommendation is going to be. It could be 6 months, it could be 4 months, it could be next year, it could be in the fall. So that's sort of a moving target, and we really don't have a recommendation on the exact time frame yet. What I did mention with the 6 months was that Moderna and Pfizer have looked at antibody titers in people who were vaccinated and found that the titers were still there after 6 months, and so they inferred from that at a 6 months time frame that most of the people are still protected, is what I meant earlier.
Okay, thank you. And then Vivian Avrahami, I think you were next.
Yes, hi. Thank you for taking my question. It might be a really strange question. Thank you for doing this. You're answering all the questions that I already had. However, I would love to find out if there is a recording of this that I can have my husband listen to as well. Since we're all in this, I've been fully vaccinated, my family has, but I do have those concerns that continue when it comes down to my 2 and 4-year-old children. So with that said, is there a recording? Because you have made amazing statements and even giving details and answering questions that I would like to pass on to my family members who seem to think that, oh, the CDC lifted this guideline of the masks and we're all vaccinated. So therefore the world has opened up, not supporting, since there are many non-vaccinated people that seem to now hide behind this. We don't need to wear masks. So is there a recording of this whole presentation that you have given and the answers that I can possibly access?
Yeah, so I think Regine probably can answer that best, but all of our Kids Health and Safety series that we do every month, like I said, on the 3rd Wednesday of the month, do get recorded and are available on the Bay Harbor Islands Community Center website. Regine, is that, I don't know if you want to elaborate on that at all, but I think it takes a couple of days before they actually become available. But if you don't see it in a couple of days, you can always shoot me an email if you want. I'm at tlevine@mhs.net. And I'll be happy to try to get you a copy if you can't find it just by Googling it or going on the Bay Harbor Islands website.
Wonderful. Thank you. I very much appreciate it.
My pleasure. All right, and then it looks like Rachel Marinsky has another question.
Yep. Sorry, me again. So I know that you guys discussed how exactly the vaccines work with the mRNA, and there was a big article in the New York Times that a lot of people are skipping out on the second vaccine. And I was just wondering if that's like another cause of potential variation, or, like how if you don't finish all of your antibiotics, it's worse because it's almost like you're teaching your body to fight it off, but not fighting it off completely. So is there risk with people not finishing or not taking all of the vaccines that might potentially also cause, from a herd immunity standpoint, more hurdles?
Yeah, absolutely. The original randomized placebo-controlled trials done by Pfizer on their vaccine showed that a week after getting the second dose, they had 90% vaccine efficacy. Between the first and second dose, you only had 50% vaccine efficacy. this was done on 40,000 subjects, half of whom got the vaccine and half of whom got a placebo, and they compared that. Subsequently, after the vaccine had been released, a study was published from Israel, because Israel, as you know, has been one of the countries that has been the best in vaccinating their population. A study came out comparing the results with their 600,000 people who received the vaccine, which is far more than the randomized control trial. And they found that similar results after you've gotten 2 doses, 90+% were protected. But after getting 1 dose, it was only 29% that were protected. So the vaccine efficacy is really, for these 2-dose vaccines, is really not there until after you get the 2nd dose. So you're absolutely right. These people may or may not be protected, and you don't know really who's protected and who's not if you only get 1 vaccine.
And also you could be partially protected, because if you have, 50% of the amount of antibodies floating around, when you could have 95% of antibodies. So still the army is weakened. The army to fight infection is not a full army. So that is, you can get sick because you don't have all the soldiers to fight, if I put it in like layman's term.
Okay, thank you.
You're welcome.
Perfect. Okay, well, I know we ran a few minutes over. I know we had some technical difficulties in the beginning. So, I think we kind of stuck with the 1 hour mark, but I know everybody has to get back to work, get back to their patients and lives and children and other things. So really wanted to thank you both so much, Dr. Ale and Dr. Chang. Wonderful talk. I think we had a lot of interest and enthusiasm, which we knew we were going to have. I'm sure there are more questions coming down the pipeline. It'd be great if maybe we can do an update kind of down the road in a couple of months, kind of reevaluate, see where we are, especially with the vaccine for kids, because there's a lot of interest, obviously, and a lot of questions that still remain to be answered. So thanks again, everybody, for participating.
Thank you so much.
And if anyone has any questions, feel free to reach out to me. I'm always available via email, tlevine@mhs.net, and I'll be happy to forward along questions to Dr. Chang, Dr. Lay, or help in any other way that I can if anything else comes up. So don't want to flood your inboxes, but I don't mind mine being flooded. So.
Thank you, Dr. Levine.
Thank you very much.
Have a great day, everyone.
Bye.
Thanks so much. Bye-bye.